It's ready. So what I'm just going to do is,
Sir, yes, sir, I
good
am ready.
evening. Yeah, I'm just going to share a few slides. This is only to help the postgraduates to see, because this is a short case which we should be finishing it say around 15 to 20 minutes. But because this particular class is meant for teaching, so we may prolong it by say around 35 to 45 minutes. Okay. So I'll share my slide now and we'll start.
Dr. Ram, postgraduate from Stanley Medical College, to present a case of cleft lip, cleft palate for surgery. It will be. I welcome Dr. Gokul Ram. Over to Dr. Gokul Ram.
Thank you, sir.
Yeah. Gokulram, are you able to see the screen, Gokulram?
Yes, sir, I'm able to see the screen, sir.
Then we'll start. Actually, class is a short case.
Yes, sir.
Normally, we around 15 minutes for short case, but because this is not exactly a practical examination, we thought we'll just slightly increase so that we'll try to put in more points for the exam graduates. So our case today is a 1-year child weighing 10 kg has got this lesion of lip and palate cleft, okay, who is posted for an elective surgery. So we'll just see how we'll manage, or how Dr. Gokul will manage from the preoperative, intraoperative, and postoperative period. The learning domains are, there are three things. One is cognitive. Cognitive is what you know. Before you touch the patient, what are things you should know? So initially we will be talking about the cognitive domain, or we'll be testing his cognitive domain. Then we'll go to his psychomotor domain. Psychomotor domain is what you will do as an anesthesiologist in the intra or perioperative period, so that you are doing a proper job, okay? Or a safe safety of the patient. And the affective domain I cannot see here, because affective domain we can see only in the operating rooms. Okay.
Yes, sir.
Right. So we'll start with our case. So, Dr. Gokul, what are the problems you expect with a patient having lip and palate?
Yes, sir. Patient coming with cleft lip and palate, the main concerns would be apart from the physiological changes in pediatric patients from that of an adult, I will anticipate there will be a feeding difficulties for the patient. So I will look for any nutritional deficiencies in the patient, and there will be speech disturbances, and there can be an associated disturbance in the ear due to the drainage of the eustachian tube. So the patient might have hearing difficulties, and the patient, if it's older children, the patient might also have a psychosocial disturbances also, sir.
So, what are the problems you expect in a newborn baby with a cleft lip?
A newborn baby with the anomalies, and the patient might have a respiratory difficulty immediately after the birth,
No, no. What
or
is the
within the
main?
first 40.
No, no, Dr. Gokul.
Yes, sir.
Dr. Gokul, just go slow. What
Okay.
is the problem you expect in a newborn baby with a cleft lip for the baby?
Uh, for the baby, there will be feeding difficulties, sir,
Why there should be a feeding difficulty?
because due to the inadequate suctioning because of the cleft lip and the palate,
Yes.
there will
If
be
the
a
patient has got
velopharyngeal
a,
incompetence, sir.
no, it is nothing to do with velopharyngeal. It's mainly the lip. For creating suction, you need the whole lip. When the lip is clefted, it is difficult for the baby to suck from the mother's breast. Okay, fine. So now, just a few words about the embryology. Could you just elaborate about how lip is formed?
Yes, sir. Lip is formed. The face anatomy embryology is from developed during the interacting period of 4th week to the 10th week, sir. Initially, there's a single frontonasal process and 2 maxillary process and 2 mandibular process. There's a nasal pit that is formed, and this divides medial nasal process and a lateral nasal process, sir. The lip is formed by the fusion of the maxillary process with the medial nasal process and the lateral nasal processes, sir.
Okay. So what are the types of cleft lip you know of?
Sir, types of cleft lip can be classified based on the View's classification. The type 1 is cleft lip that is associated only with the soft palate. A cleft lip can be unilateral or bilateral, sir. Cleft palate can be...
Dr. Gokul, just
yes, sir.
Listen to the question. In the exam, you are supposed to listen to the question.
Okay, sir.
Very clearly, what are the types of cleft lip? I have not come to cleft palate. Okay, when
Okay,
I ask you about lip, we'll have to say only about lip. Okay, yeah.
Yes. Cleft lip can be either unilateral or bilateral cleft lip, sir.
Very good.
And it can be either a complete or incomplete cleft lip, sir. And complete lip from the lips to the nostrils, sir. And incomplete, it will be just a cleft in the lips, sir. It won't be extending into the nostrils, sir.
Okay, right. So tell me, how is the palate developed?
Palate is developed as a 2 types, primary palate and a secondary palate. The primary palate is in front of the dental foramen, and it is formed by the...
Is it dental foramen? This is not dental foramen.
Incisive foramen.
Foramen, yeah.
Yes.
Palate that is present anterior to the incisive foramen.
Anterior to the foramen, it is formed from the back growth of the maxillary processes, sir, and the fusion of the nasal septum. And the posterior palate is mainly formed by the palatal shells, which fuse in the midline, sir.
The posterior part is from the palatine bone.
Palatine.
Maxilla. Okay.
Yes.
Right. So could you now tell me what will be the different types of palate?
Yes, okay. Cleft palate can be type 1, which can be just confined to the soft palate, and second type can be involving both the soft palate and the hard palate, and third type can be unilateral cleft lip and palate, which is a complete cleft lip and palate, and the fourth type can be bilateral complete cleft lip and palate, sir.
So what was our case?
Our case is a unilateral complete cleft lip and palate, sir.
No, unilateral.
Complete.
Complete.
Cleft lip and palate, sir.
But you're not mentioned one important thing. Which side is it?
Yes, sir. Left side, sir.
Can you have it to the right side also?
Yes, sir. It can be there.
So can there be any anesthetic significance with having a cleft lip on the left side? Left lip. You said unilateral complete lip and palate on the left side.
Yes, sir.
Does it have any specific anesthetic implication?
While intubating the blade, the flange of the blade may enter into the cleft, sir. So we have to take a precaution while intubating by by keeping saline soaked gauze before introducing the blade, sir.
Yeah, very good. So that is what we'll ask you in the exam. Fine. Now, could you just tell us what are the common etiology for this cleft lip and palate? Is there any etiology or it's something different?
It can be both. The exact etiology has not been found, sir. It can be due to genetic or environmental causes. The environmental causes that have been found are alcohol consumption in the mother, or certain drugs, and it can be due to other environmental causes. Right?
No, you said drugs. I'm interested in knowing what are the drugs.
Yes, sir. It can be associated with some
anticonvulsants.
Anticonvulsant like phenytoin drugs, sir. Fetal hydantoin syndrome with cleft lip and palate, sir.
Okay, fine. Now you tell me what is meant by a syndromic child and what is a non-syndromic child?
Yes, sir. A syndromic child due to a developmental anomaly that has a multiple associated defects, sir.
Okay.
And
Isolated lip and palate is different from a syndromic child. Okay. What are the common syndromes which you get this lip and palate? Can you name few?
associated common syndromes are Peary-Robbins syndrome, Treacher-Collins syndrome, Down syndrome, Golden Heart syndrome, and velocardiofacial syndrome, and fetal alcohol syndrome, sir.
Okay. Could you just explain what is the difference between a Peary-Robin and a Treacher-Collins, or otherwise what we call it as catch-up growth? What is meant by catch-up growth?
As a Peary-Robbins sequence, the patient usually develop improvement with the aging, sir. While it
Very
is
good.
contrary in Treacher-Collins syndrome, where the patient or the baby will deteriorate as the aging happens, sir.
Okay. Could you just tell me few parts of a Peary-Robin sequence?
Yes, sir. Peary-Robbins sequence, the important features are there is retrognathia, due to which there is glossoptosis or posterior protrusion of the tongue, and associated U-shaped cleft palate, sir. And due to this, the patient might have immediate airway obstruction in the early neonatal period, sir.
What will you do in the early neonatal period if you have a baby with a Peary-Robin having respiratory distress?
Yes, sir. First, we have to assess the degree of obstruction, sir. So,
The
if we
baby
can,
has got obstruction now,
yes,
but
sir, we have to immediately change the position to prone position, sir.
that's all. You keep the baby in prone position,
Prone
then
position.
any other method can use.
We can lateral tilt only in some patient might have improvements, sir.
Okay, change of position. Anything?
Change of position. Nasopharyngeal airway will be of my good help, sir, in this patient, sir.
Okay, that will be very temporary thing.
Yes,
Any
sir.
non-invasive ventilation can be done.
So, continuous positive airway pressure can be given, sir.
Okay, fine. Then we will go to the next syndrome. How do you measure this retrognathia? Because you said retrognathia.
Yes, sir. Retrognathia can be measured from the lateral aspect of the patient, sir.
Hmm.
We can measure the amount of retrognathia or mandibular length, sir.
Mandibular length means you are talking about this length.
Yes, sir.
How do you measure and say this patient has got retrognathia?
We have to see from the upper jaw, sir. So if the mandible is equal to the upper jaw, draw a midline from the.
No, just relax. Nothing, don't worry. You have three bones here. One is the frontal bone, and is the maxillary bone, and is the mandibular bone. At the level of the pupil, keep a paper or something and see the lateral side. Okay. If the paper is touching the frontal bone, touching the maxillary bone, touching the mandibular bone, then we call it as normal. If the paper touches only the frontal bone, and it touches the maxilla, and it is not touching the mandible. It is because the mandible is gone back. So this you measure the retrognathia. In the many of the examiners will ask you, if you say retrognathia, how do you measure? And this is the measuring retrognathia. Tell me something about retrocolling.
Sir, Treacher-Collins syndrome is mainly associated with the hypoplasia of the maxilla, sir, and
No, you have to be very specific. It is bilateral,
symmetrical abnormality, mainly due to the hypoplasia of the facial bones, mainly the maxilla, mandible, sir.
Even the zygoma is also
Even the zygoma is also involved, sir. And the patient might also have associated eye and the ear problems, sir.
Okay. What is the problem you expect in these patients?
The problem I expect is there will be a respiratory difficulty that will be progressive as the patient matures, sir.
Not the respiratory difficulty, the difficulty of laryngoscopy and intubation.
Laryngoscopy. Yes, sir.
More difficult as the child grows.
Yes, sir.
Okay, what is the next syndrome? Golden hair. Tell me something about golden hair syndrome.
Golden hair, there is hemifacial macroglossia, sir.
Yes, it's only hemifacial.
Yes, sir. There will be
Major problem
asymmetrical.
here.
Sir,
What
the
will
area
be
of problem
major,
is the branchial arches, sir.
what will be a major anesthetic problem here?
Anesthetic problem will be same, sir. There will be a difficulty in intubation, and the mask
No.
ventilation itself will
Mass
be
ventilation. Main
difficult for.
difficulty is mass ventilation. Then they can have associated problem because of other issues. So whenever you have a syndromic child, always be prepared for a difficult airway, which could be difficult mass ventilation, difficult laryngoscopy, difficult intubation. Sometimes they may even have a difficulty in phona. Right.
Okay.
So what is this baby with a short neck?
Yes, sir. Klippel-Feil syndrome, sir. There will be
Is it
associated
associated with palate or lip?
with palate only, sir.
It's mainly associated with palate. What is the problem?
There will be associated of vertebral anomalies, sir. Mainly the cervical spine.
Okay.
So there will
Here
be a
it-
limitation of the neck movements.
Okay, there is a fusion of
the lower cervical spine.
So these babies, if you just see the baby, you can find the baby has got an abnormal neck position.
Yes, sir.
Palate patient with this type of a neck positioning, always check a X-ray neck or a whatever thing that you radiological imaging you want. These
Okay, sir.
have a difficulty in intubation, and you should and in such a way that you straight away go for a fiber optic.
Okay, sir.
Coming to a beautiful Downs baby, what are the problems with Downs baby?
Down's patient, they'll have a unstable spine, so they'll have webbed neck. So the extension now also will be difficult, sir.
They don't have webbed neck. They have something else. They have a atlanto-occipital.
Dislocation, subluxation.
No, it is only instability. So what is the anesthetic problem here?
While we extend, there can be a.
Very good. When you have a Downs baby coming for palate, always assess this and always try to keep the position as minimal as possible, because our positions, we keep it in a more extended position.
Extended position.
So tell the surgeon, this baby is a Downs, and check the cervical spines. So better to avoid too much of extension.
Okay.
Right. So now we have seen few of the syndromes, and these are syndromes that they normally will ask you in the exams. So now we preoperative evaluation. Now we have our patient who is 1 year 10 kg with less complete lip and palate, cleft lip and palate.
Yes, sir.
How are you going to do a pre-op evaluation?
Yes, sir. First, I will do a complete physical examination, and
So before physical examination, what will you do?
I will ask a complete detailed history from the patient, sir.
Very good.
Including the associate.
Proceed.
Yes, sir.
Proceed.
I will have. Yes, sir. I'll ask for history of any immediate difficulty after birth, and associated with difficulty in feeding, or any recurrent operations in the baby, and any
So
signs
what
of
will the
any.
history tell you? Recurrent respiratory tract infection in a baby. What does it tell you?
Yes, sir. Recurrent respiratory tract infection will tell me there will be a higher chance of airway compromise in the patient, and there will be
No,
a
no, no.
nutritional
Recurrent
deficiency.
respiratory tract infection in a 1 year child tells you something. You will have to examine this. What is that? Recurrent respiratory tract infection.
Associated cardiac.
Congestion. Yes. Whenever
Cardiac
presents with a recurrent respiratory tract infection, always think of some kind of a cardiac anomaly. We know when you have one congenital anomaly, they can have some other also.
Yes, sir.
Right? Okay. What are the other questions that you'll ask in the pre-operative evaluation room?
Any signs of any hearing difficulties?
Mm-hmm.
Any new signs of nutritional deficiency, and
Deficiency also, you don't ask. No, what are things you'll ask?
I'll ask for
infections.
infections and abnormal face is due to the syndromes and
Those things you don't ask, those things you see.
yes,
Those
sir.
are called as regarding symptoms.
Yes,
You
sir.
said recurrent respiratory tract
Any
infection.
history of any obstructive sleep apnea, that is snoring during the
Okay, it's
sleeping
just
activity?
snoring.
Yes, sir.
Anything
And
else?
any color discoloration, cyanotic spell or
No,
discoloration?
your cleft palate child, will they have secretion in the nostril or not?
No, sir.
They'll be dry. The
They,
nostril will be dry with the palate.
um,
When you auscultate, will you get some crepes in a patient
yes,
with palate?
yes, sir.
Yes. Why?
Regurgitation or aspiration can be a risk in this patient.
No, not aspiration. Regularly, they have a hole in the palate. So whatever
Okay.
they eat, it stays there, and you will see a runny nose.
Yes, sir.
Okay, patients with palate. Are you worried about runny nose in a palate in a patient, 1 year patient?
Yes, sir. Any increased secretion or hyperreactive airway can provoke sudden laryngospasm during airway manipulations.
So you're worried
So
about respiratory tract infection.
infections.
So how do you differentiate a respiratory tract infection from just a secretion that has gone from the mouth to the nostril in a sound?
Um, I will see for other signs, sir. Chest, I will auscultate the chest and associated
Okay.
any uh, changes in the breath sounds, more likely to be a respiratory tract infection, and
Mm-hmm.
continuous symptoms which does not have any which are aggravating or relieving factors, sir.
Mm-hmm.
Will more likely towards be a upper respiratory tract infection. So
Now,
if there is occasional
which one will say this patient has got upper respiratory tract acute infection? Because infection, I'm worried.
febrile fever will
Yes,
be
patient
associated.
is your fever. Anything else? You want,
uh, Feeding difficulties,
no. Anything else you want to check and say this patient has got infection? It is not because of just an allergy or
blood investigation,
what investigation you want.
total count and differential count can be
Okay.
seen, sir.
Okay. Anything in the face that will tell you the patient has got infection?
Um,
Facial congestion, eye
Congestion
congestion.
will be the redness and congestion of the
Okay,
face.
fine. Okay, right. Anything else you want to see the operative evaluation?
Um, yes, sir. Preoperative evaluation, I will
You
blood.
want to assess the airway?
Yes, sir. I will assess the airway, sir. Detailed assessment of the airway is very important, sir.
How do you do
Uh,
Malambati?
I will do for pediatric airway. I will do a copper.
No, will you do a Malambati or not?
Yes, sir. We can't exactly do a malamati. We can ask for if the patient, if the child is older,
So
we can see for open
your
1 year.
child is 1 year and 10 kg.
Yes, sir. So malambati grading will be difficult for this patient,
So
sir.
it cannot be done in this age group. This is
Yes,
mainly
sir.
for a child who can cooperate with you, most like
Yes, sir.
for 8 years. Okay. So now tell me, how will you assess an airway in a pediatric patient?
Yes, sir. I will use a copper method of airway assessment, sir.
What is that copper method?
Copper method is first I will see for the mandibles, chin, sir. I look for obvious retrognathia, and we have to examine from the side of the patient. First, we have to see for the chin. It is moderately hypoplastic or markedly hypoplastic. We have to assess, sir. Based on that, we can score from 1 to 4, sir. Then O for opening of the mouth, we have to see the interdental distance, sir. That can be ranging from, if it is more than 4 centimeter, it is normal, and the grading actually progressively increases, sir. And we have to ask for the history of any documented previous difficult intubations or any history of obstructive sleep apnea, sir. um,
Okay.
and I will ask the baby to put the for the older adult, I'll ask the baby to put the mouth
No,
open and
your
perform.
baby is 1 year.
So I will manually try to open the mouth, and if I'll see if the uvula is visible or not, sir.
Don't try to do manually. If the child cries, you just bend your head, go see
Okay, sir.
if Yula is able to see it or not. Okay, then.
Okay, sir. And I will see for the range of neck movement, sir. And
Okay.
if it is more than 120 degree, it is normal, sir. Based on the scoring system, will categorize point, and if the scoring is more than 10 points, it predicts a difficult airway, sir.
So if it's a difficult airway, what are the things that you like to keep ready?
Yes, sir. First, I will make a difficult airway card ready. I will
Now,
have the
what equipments you need this particular baby difficult airway?
yes, sir.
What?
I will appropriate size face mask, and
Okay.
I will have a, Macintosh blade or a Miller blade with one size and two size available, and
Okay.
appropriate size endotracheal tube, 3 and 3.5 internal diameter endotracheal tube. Since
Hello.
it's a fifth surgery, I'd
Alright.
like to
Returning
have
வரீங்களா?
uh, I'd like to have a ring adder Elvin tube.
Mm-hmm.
I'll also have
Video laryngoscopy.
a stillet or a pediatric bougie if the video laryngoscopy is
Okay.
and if the patient is having very syndrome, I'll also have a pediatric fiber optic bronchoscope, sir.
I want to know what type of
And
fiber, what size you want.
picothyrotomy set in the
Cricothyrotomy in this age group,
uh,
it is not possible to do cricothyrotomy
I don't know,
till the age.
sir. It should be the last.
No, there is no place for cricothyrotomy in pediatrics up to the age of 7. It is only tracheostomy. The cricothyroid membrane length is only hardly
Yes.
2 millimeters. So never say cricothyrotomy in a pediatric patient. It's
Okay,
always
sir.
tracheostomy. Okay, right. So you kept.
Tracheostomy.
So now, what is the age at which you'd like to operate?
Yes, sir. I will try to operate usually the cleft lip is operated early, sir. It is operated at the age of around 3 months to 6 months, and the cleft palate is operated late, around 9 months to 12 months of age, sir.
Okay. Some centers they have started doing a neonatal lip because to save the mother from the psychological depression.
Psychological depression. Okay, sir.
But it has got its own problems because the latest guideline says avoid giving any elective surgery, anesthesia for any elective surgery in
Yes.
neonatal period because of apoptosis problem. Okay,
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 sir.
fine. So, what are the investigations would you like to do?
I would like to do hemoglobin to have a baseline value and to assess the nutritional status of the patient. I would like to do a total count and differential count to rule out any patients. And
Okay.
I would like to do blood grouping and cross matching for the patient. If
Okay.
the palatal surgery is also planned, and if the patient, I will also try to rule out other associated congenital heart problems by doing a echocardiogram and electrocardiogram, sir.
Okay.
And if I suspect any coagulation, I'll do a bleeding time and a clotting time, sir.
So, do you know anything about the rule of 10 for lip
Yes,
and
sir. Killness rule of 10 for cleft lip is we have to operate the ideal time of operating, that is around 10 weeks of age and 10 grams of hemoglobin, and the weight of the patient is around 10 pounds. And for cleft palate, it is 10 months of age and 10 kilograms of weight, and um, the total count should be less than 10,000, sir.
Okay, fine. So, based on your preoperative evaluation, we will take this patient has got a difficult airway.
Yes,
This
sir.
doesn't have infection, but they have taken a swab and they are given some prophylactic antibiotics also, which is
Yes, sir.
again the interinstitutional things.
Okay.
And the patient is ready for surgery, and you have assessed the patient. Now we are going to take the patient for surgery and anesthesia. What is your plan of anesthesia for this baby?
Yes, sir. My plan of anesthesia would be endotracheal intubation with controlled ventilation, sir.
Is it very endotracheal intubation, or you give something and put endotracheal intubation? Anesthesia with endotracheal intubation. Okay. You want to put a blind oral intubation and control ventilation. So always be very precise in what you say, right? Your plan is general anesthesia, control ventilation.
Control.
Okay, fine. So now tell us how will you proceed step by step from pre-operative till post-operative.
Yes, sir. I will first visit the patient in the pre-operative day, and I'll explain about the procedure to the parents, and I'll instruct them regarding the nil per oral guidelines.
So what is the latest need per role guidelines?
Yes, the latest nil per oral guidelines. The baby can be given clear fluids up to for the first. We had stop clear fluids for at 2 hours of, before the procedure, and breast
What do
milk
you
can
mean by
be.
the clear fluid?
Clear fluids are non-particulate containing fluids, so that light can easily pass through and we can see objects on the other side of the fluids.
So what is the present guidelines or recent advances which says is it 2 hours or less than 2 hours?
The gastric emptying time is actually even less than 2 hours, sir. So up to 1 hour we can give, sir.
Yes, you can give a clear fluid up to 1 hour, but in I ask you just stick on to what given in the textbook, that is 2 4 6. Okay, right. So this is 10 kg baby. So I
Yes,
want to give clear fluid. What fluid will you give? How much will you order?
Yes, sir. 10 kg baby for clear fluid, we can give uh, like a coconut water or some carbonated drinks or sweetening agents, or we
For
just
one
plain
month
water.
baby, you want to give carbonated drink?
No, sir, not for a
Okay,
1 month.
some clear fluid means water or dextrose containing solution.
Dextrose containing, sir.
Will you give half a cup or 1 cup?
Yes, sir. So I'll give around for 50 to 100 ml per.
No. It is purely 2 to 3 ml should be the maximum. You cannot give 50 ml. Okay.
Okay.
If 2 ml, it is going to 20 ml for your patient. You cannot
Okay, sir.
give ml and say my patient is nil oral.
Okay, sir.
And which is the best method of finding your patient is not going to regurgitate? Or how do you measure the amount of fluid in the stomach?
We can measure using the ultrasound assessment of the gastric volume, sir.
Gastric antrum.
Antrum
The
volume.
gastric antrum and the volume.
Yes.
Very good. Okay. So what are the advantages they claim by giving fluids within 2 hours?
The hydration of the patient is maintained, and the baby is more calm and comfortable during the uh, in fear. Uh,
What is the most important
patient is
reason why?
not very little.
Yeah. What is the most important reason why we want to give fluid within 2 hours? What all things you have said is okay, accepted. What is the most important reason why we should give fluid within 2 hours? What happens when you give fluid? Actually, what they have found is when you give fluid, the stomach is. Are you able to hear me? Hello? Hello? Gokul, are you able to hear me?
Dr. Gokul?
Hello?
Some connectivity issue.
Some kind of connectivity issue.
Yes, he's getting back.
symptoms?
Thirst and hunger are reduced, sir.
Fine. Most
And
important reason.
reduces the anxiety for the parents and enhances the gastric
That is very good. That is, yes.
The
Most
pH is
important
reduced.
thing is,
pH is
the
reduced.
not the pH. Most important thing is when you give fluids, it makes the stomach contract. So there is a faster gastric emptying, so less chance of patient going for aspiration. Okay, right. So now the patient, you are given the instruction of fasting guidance. What are the monitors you want for this patient?
Routine monitors.
What monitors you want? So there is too much of noise disturbance. I request all the others who are not
Dr. Gokul is back, sir. He's joined us.
back. Is it?
Sorry,
Okay,
sir.
fine. No problem.
Some
No problem.
connection.
Okay, no issues. Gokul, now tell me what are the monitors you keep before stomach stage?
Sir, I will attach monitors, including electrocardiogram, pressure monitor, finger pulse oximeter, and pre-pulse, sir. And after intubation, I'll auto attach ETCO2 monitoring, sir.
No. Just tell me what are the monitors you will keep. That's all. After intubation, we are not gone to that level of intubation.
Okay, sir.
Okay. What type of tube would you like to have?
I'll like to have a ring adder Elvin tube, sir.
You want to have a ring adder Elvin tube? Could you just tell me about what is a ring adder Elvin tube?
Ring adder Elvin tube is a preformed curvatured tube, sir. So their preformed curvature is there, so that during shared airway, the circuits and anesthetic circuits can be out of the views from the surgeon's view, sir. And
okay, that is the advantage. What are the disadvantages of using this tube?
There is increased resistance to airway, and also there is increased difficulty in suctioning the tube. And since there is a preformed curvature for an average sized pediatric patient, our patient might be the size may be more higher or lower, sir.
Okay, if you select the wrong size tube,
it can either cause accidental extubation or endobronchial intubation of the tubes.
Very good. So you want the red adder Elvin tube. Accepted. Okay. So now we come to our patient, and this is our patient who has got a left side complete lip and palate planned for our surgeon wants to do at 1 year both lip and palate. Okay.
Yes, sir.
On alone now. Now tell me, would you like to pre-medicate this child or not?
Yes, sir. I would like to pre-medicate the child.
Pre-medication, how much?
I like to pre-medicate with anti-sialogogue, sir. First, yeah.
Yeah, you can go ahead. Go ahead.
Yes, sir.
Yes, sir.
From now onwards, you can say whatever that is being done in your institution. Don't bother about the textbook or same book. Just tell us what is being done in your institution. Save you in the exam. Fine? Yeah, proceed.
Yes, sir. I will try to avoid any pre-medication, sir.
Okay.
The patient is really irritable. Once after giving a
So
what do you want
to give now? You want to give glycopyrrolate. How much of
5 microgram per kg, half an hour before the procedure, sir, before shifting to
what are the advantages that you claim with glycopyrrolate?
there is decreased secretions intraoperatively, sir. Since the patient might also have a running nose, there will be a increased airway secretion will further cause increase in the difficult airway, sir.
No. Running nose, what will happen? Your glycopyrrolate to make it dry.
Make it dry, sir. Yes, sir.
So that is advantage.
Yes, sir.
The secretion, the bronchi, if it gets dried, is it okay for you?
Yes, sir. For during sir.
No. We cannot accept a secretion in the intratracheal or intrabronchial tree being dried with glycopyrrolate is not an advantage to the patient. It is very difficult to remove if the suction is going to
Thick
increase.
secretions. Okay, sir.
That is a disadvantage for using glycopyrrolate. Any other advantage or disadvantage of glycopyrrolate? Why do you want to give pre-medication? What are the reasons you want to give pre-medication?
To reduce the anxiety of the patient, to reduce the secretions, and decrease the hyperreactivity of the patient, sir. I would like to also add a nebulizer.
Decreases hyperreactivity. Okay.
No, sir. For that, I will give a nebulization with salbutamol also, sir.
Okay, that is different then. Should have got an history that the patient is a known wheezer.
Yes,
You
sir.
don't co-director for all the patients, no?
Yes, sir.
Okay, then any other reason why you want to give pre-medication? Anything?
Sorry, sir, not able to.
No. Are you expecting a bradycardia in a baby patient? Pediatric?
Yes, sir. There is increased vagal parasympathetic activity to the heart, and increased parasympathetic innervation to the airway, mainly the pharynx, and also any manipulation will more likely cause bradycardia to the patient, sir.
Which one is advantage? Is it atropine or glycopyrrolate?
Atropine is more advantageous, sir.
Okay, right. So, okay, fine. Then you said glycopyrrolate or atropine. Is there any other route by which you can give these anticholinergics?
Yes, sir. Atropine syrup is available, sir. Oral medication.
Is it available? Is it available?
I'm not sure available in my place.
No.
Sir.
Just tell us what you do in hospital.
Okay, sir.
There, if you are going to give IM glycopyrrolate, I'll accept it as IM glycopyrrolate.
Okay, sir.
Okay. You said you are worried about giving from benzodiazepines.
Yes, sir.
Okay. Suppose if at all we ask you to give a benzodiazepine will you like to give, and how much will you give? In which route?
I'll give a oral midazolam, sir, 0.5 mg per kg, sir.
Okay, fine. I will take up that you are given both oral midazolam and oral atropine or IM glycopyrrolate, whichever you want. Okay.
Yes, sir.
Right. Now I have another patient here. What is the difference between these two patients?
That's a bilateral cleft lip, sir.
Bilateral cleft lip alone.
Also the palate, sir.
So for this, you said initially that you will keep some wet gauze.
Wet gauze, yes, sir.
Pack. So what is the problem with this baby? A freely hanging premaxilla.
The freely hanging premaxilla, it has end arterial nervous supply, sir.
So if you have this patient, you'll have to be very careful doing a laryngoscopy.
I will try to avoid any damage to the tip.
It will damage. Okay, fine. Right. Now you are given pre-medication. How are you going to induce the baby? We'll take up alone.
Yes, sir. I would like to use inhalational induction for the patient, sir.
Tell me, how will you do that?
Yes, sir. I will try to put a intravenous line for the patient in the awake state, sir.
Okay.
After securing intravenous line, I will give sevoflurane oil after attaching all the monitors, and I will check the machine, everything is checked, and I will use a Jackson tree circuit, and with the appropriate face mask, I will give 8 liters of oxygen and induce the child with a sevoflurane of initially 2%, and after every 60 to 90 seconds, I will increase the dosage of sevoflurane to 1 mg, that is 2% to 4%.
So this is called as what type of inhalation induction?
Step up method of inhalational induction.
Is there any other method of induction?
Yes, sir. There is also step down method where we initially keep very high concentrations of inhalation agent and gradually step down once the patient has loss of consciousness, sir.
Okay, done. Then
Yes, sir. Once I see certain signs such as fixed gaze of the patient, and the jaw muscles and the limb are relaxed, and the respiratory pattern, which will be initially slow and regular, in the second stage it will become shallower and increase the rate. Then only I will try to manipulate in that state, sir. And first I will do a trial laryngoscopy.
So
And
what do you mean by trial laryngoscopy?
a triangle laryngoscopy is done without any muscle relaxation given, sir. The
What
patient
are
is
the
still
things you
in.
want to know? What are the things you want to assess during trial laryngoscopy?
I like to see what portions of the glottis or epiglottis I'm able to visualize during trial laryngoscopy, and whether even introducing the blade or visualizing is anything is difficult, sir.
Okay, right. Done. So I'll take it that you have done a trial laryngoscopy. Proceed.
Yes, sir. If the triangular laryngoscopy is, I am able to see a portion of glottis, then I will give a muscle relaxant, and after giving a muscle relaxant,
What
I will.
muscle relax? What muscle relaxant? What is the dose?
Yes, sir. Since I am confident that I am able to secure the airway, I will give a non-depolarizing muscle relaxant injection, atracurium, 0.5 mg per kg, sir. That is around 5 mg for the patient, sir.
Is the patient having a normal airway or a difficult airway?
Difficult airway, sir.
So is there anything that any precaution would you like to take regarding your non-depolarizing muscle relaxants?
Um,
Would you like to use any particular type of a non-depolarizing muscle relaxant?
yes, sir. I'd like to do a muscle relaxant which can be reversed like vecuronium or rocuronium, sir.
Okay, why? Why not attract?
Uh, Vecuronium rocuronium can be reversed with Sugamadex, sir, if there
Fine.
is cannot intubate, cannot ventilate situation.
Steroidal non-depolarizing
Steroidal non-depolarizing agents.
can be reversed with Sugmadex. Fine. But what we have now is, which is better, Vecuronium or Rocuronium?
Rocuronium is better, sir. If we can give in a higher doses of 1.2 mg per kg, we can intubate early, sir. That is even rapid sequence intubation can be done, sir.
Okay, right, done. Yeah, proceed. So
Yes,
you're
sir.
patient and you're given a relaxant.
Yes, sir. After ventilation, I'll intubate the patient. Before intubation, I will place saline-soaked gauze over the cleft, and I'll try to reduce the number of. I'll be gentle in my intubation and minimize the traumatization to the oral cavity, and I'll intubate with a ring adder Elvin tube of size 3.5 millimeters internal
Okay,
diameter.
now you're trying to attempt it with a laryngoscopy, but you're
Yes,
not able to intubate.
okay, sir.
You do.
Uh, for before my second attempt, I will recheck my position of the patient, and I will first call for help, and I will try to correct any correctable issues, so like the position of the patient, and if there is any misplacement or better different type of tube like a Miller blade, or if there is a increased size I need, I will change the blade to increased size, and I'll try for a second attempt, sir.
Okay, still you're not able to intubate.
Yes, sir. Even after intubation, now I will try to uh, maintain the airway with the supraglottic airway device, sir.
So what size of supraglottic airway would you like to put in this patient 10 kg?
10 kg, I would like to put 1.5 or 2 size LMA, sir, per kg.
1.5 or 2?
Yes, sir.
1.5 or 2, which one?
2 size.
Okay, so you have put an LMA and you're able to ventilate. Now you know there was a difficulty in intubation. So
Yes,
what
sir.
methods by which you can intubate a cleft lip and palate patient other than the conventional method?
Yes, sir. We can use a video laryngoscope.
Okay,
We can, in using a laryngoscope, we can use a paraglossal approach, sir.
what is that paraglossal approach?
Paraglossal approach, we have to use a straight Miller's blade, and we have to introduce the blade through the right side of the mouth. We have to bypass the molar, that is the retromolar, and we are going to bypass the tongue to the right. So the entire tongue will be shifted towards the left, sir. And the head is also rotated like slightly towards the left to facilitate more visualization. And if any pressure is needed, we can ask for external laryngeal manipulation, and we can intubate to this, sir.
You'll have to very clearly say,
Yes, sir.
we rotate to the left and the external maneuver to be to the right. Then
To
you
the right. Yes, sir.
get a maximum
Maximal view.
visuality. Okay, you're done. You are visualized. Then what will you do?
Then I would like to insert a stillet and then intubate the patient, sir.
Just a stillet and intubate, or do you want to make anything in that stillet? Difficulty was more because it was a anteriorly placed larynx.
Sir, I bend the end of the stillet.
Yeah, you make it as a hockey stick shape.
Hockey stick shape of the stillet, the railroad behind the epiglottis.
So this is one method of doing
Yes, sir.
intubating. What is the best method of intubating a difficult RV?
Best method, video laryngoscopy.
Video laryngoscopy will only show.
Yes, sir.
The best method to intubate.
Fiber optic.
Golden standard. What is the golden standard for intubation?
Fiber optic bronchoscopy.
So you use a fiber optic bronchoscope, either directly
or through the LMA we can.
You already put an LMA.
Yes,
so
sir.
LMA you can put in this fiber optic and you can intubate. Okay.
Yes,
right. So now you have intubated the patient. It's accepted. So now the surgeon wants to position the patient. So what are the precautions as anesthesiologist you will take to position this patient?
For cleft lip and palate surgery, the position will be in extension position of the neck. So I will try to periodically auscultate the chest for and look for any prevention to any displacement of the endotracheal tube. There can be both accidental extubation of the tube and also endobronchial intubation, sir.
When will it get extubated? When will it get intubated? Endobronchially.
During extension, the tube can be accidentally extubated, sir.
Very good.
And while applying the mouth gag.
Okay. We are talking about position. We have not gone to the mouth gag.
Okay, sir.
So you have checked everything. You are positioned. And if it's a Down's patient, what will you do?
A shoulder roll can be placed to accept the
Down's
extension.
patient.
I will avoid to extend the neck very much.
Extension. Okay. So you have positioned the patient now. Yes, proceed.
After positioning, after rechecking and confirming the tube is in position, I will watch whether there is any compression during the application of mouth gag, sir, which is commonly placed in these surgeries.
What are the mouth gags you know of?
A Boyle-Davis mouth gag and a Dingman mouth gag. The Dingman mouth gag has a space for the endotracheal tube in the midline, sir.
Okay. So what are the things you will check as the surgeon opens up the mouth gag?
Yes, sir. There can be a compression of the endotracheal tube during opening of the mouth gag. So I will.
How will you know there is a compression?
There will be a tightness of the bag or increased compliance, sudden increased resistance to the ventilation, sir.
Okay. Then.
And auscultation, there will be decreased breath sounds. So I will try to place a gauze roll or cotton roll.
Anything in the ETCO2?
ETCO2 will be reduced, sir.
Reduced.
Airway pressures will be increased.
Okay. If there's going to be increase in back complaints, what will you do?
Increase in blank complaints, I would like to check from the patient into the machine end, sir.
No. In this particular case, in this particular situation, it becomes tight, ask the surgeon to release first. 90% because he has compressed the tube. Okay, right. Now you have positioned the patient. Now you said you are connect. You have started a line. What fluids will you like to give? How much would you
Yes.
like?
I would like to give 1% dextrose containing Ringer's lactate. I'd like to fasting, will also the uh, due to and I lap and loss the first half of the fasting loss will be replaced in the first hour, and the second and third hour I replace the half of the fasting requirements, sir. And during the second and third hour surgery, I add the loss due to for this patient 4 ml per kg based on the Harley-Davidson formula. I'll take as 40 ml per kg of maintenance fluid, and if the fasting is around 4 hours, 6 hours, 6 hours, I will give a 240 ml.
But you are given very clear
Divide that
guidelines.
into ml in the first hour, 60 ml in the second hour, and 60 ml in the third hour. Sir?
Okay. Because you said your guy fasting 4-8. So don't take the measurement to 6 hours. So you'll be giving lots
Yes.
of fluid intro.
Any fasting.
Purely based on how many hours of fasting. Okay, proceed. Intraoperative, first or maintenance, then maintenance. What else you want to add?
In yes, sir. I will maintain the. I want to add nitrous oxide, oxygen, and sevoflurane,
No, no, no,
sir,
no, no, no. You're
and
still in the
intermittent
fluid.
boluses of muscle.
Doctor, you're still in the fluid. Dr. Gokul, you're still in the. Am I audible? You are still in fluid management. You say first or maintenance.
Dextrose, yes, sir.
Yeah, that is accepted. For maintenance, you said you will give 40 ml. Is it okay to give 40 ml of maintenance, or should we increase or reduce? What is
Yes,
the recent
and
guidelines on giving maintenance? How much you should give? You give only 70% of the maintenance fluid.
30 ml over starting. Yes, sir.
I can't. All maintenance fluid
Hello,
you
sir.
give only. Can you hear me?
Sound. Yes, sir. I'm able to hear, sir.
Right. So
Hello.
maintenance fluid.
Yes, sir.
So maintenance fluid, you don't give 40 ml. You give only 70% of the calculated mean. That is the recent guidelines. So you can give only 30 for the first hour maintenance. Then is it a major surgery or minor surgery?
It is a intermediate surgery.
So if it's going to be a moderate surgery, what is the tissue fluid loss you expect? How much of tissue fluid loss you are going to replace?
Around 5 ml per kg per hour. Intraoperatively, I
Around
like to
5
replace
ml.
around per kg per hour, sir.
Would you like to give blood for a patient getting operated for palate?
Yes, sir. I'll first estimate the maximum allowable blood loss for the particular patient.
Okay.
If it is exceeding the maximum allowable blood loss, I would like to replace with packed.
How do you calculate how much of blood loss you can allow? Maximal allow.
Maximum allowable blood loss is calculated based on the formula. First, you have to calculate the estimated blood volume for the patient. Since it's a patient of 1 year and 10 kg, I will take 80. There will be increased extracellular fluid volume. I'll take 80 ml per kg of fluids. So there will be 80 ml, and I will initial packed PC packed cell volume and my target.
80 ml per kg.
Yes, per kg.
Per kg, what will be the blood volume?
Sorry, sir.
80 ml per kg. So what will be the blood volume of this patient?
For with this patient, it will be 800 ml, sir, 10 kg.
Okay.
And I'll based on the initial hematocrit value, I'll if initial hematocrit.
Okay. I think you don't know the formula. Just go and read the formula for calculating what is the maximal allowable blood loss, which is based on patient's hematocrit and what is the lowest hematocrit you can allow. Okay. From that, you calculate how much of blood that you're going to give. That is going to be based on patient's hematocrit
Minus initial hematocrit divided by the patient's hematocrit.
No, just don't try to mug up the formulas. Just think, okay? For maximal allowable blood loss, you will take patient hematocrit to a minimally allowed hematocrit.
Yes,
For
sir.
that, you take the patient hematocrit or the perioperative hematocrit to the maximal level that you want to take. So that will be the ideal hematocrit. Okay?
Yes, sir.
And how much of hematocrit the patient's blood that you are going to transfuse. In our institution, they say it is 60 is the hematocrit of our packed cells. So depending upon the institution, it could vary between 60 and 70. You have to go by that. Okay. So you will give that. Fine. Right. Coming to the analgesic part. You didn't say anything about the analgesic part.
Yes, sir. I'll give a opioid analgesic of injection fentanyl, sir.
Mhm.
2 microgram per kg. 20
Okay.
microgram initially I will give, sir.
Okay.
And I'll supplement with injection of my acetaminophen of 15 mg per kg, sir. 150
Which
mg
route? Which route?
intravenously during the procedure, sir. And
How many ml?
sir,
How
15
many?
ml, sir.
How is it available?
It is available as a 100 ml solution containing 1 gram, sir.
How will you give? Will you take it in a separate syringe or will you just give?
I will take it in a 10 ml syringe, sir, and I will give a slow IV infusion, sir.
Why you are not connecting that 100 ml to the patient circuit?
Uh, because I can't exactly monitor the amount that is going to the patient, sir.
Suppose the whole bottle goes into this patient, what will happen? Whole 100 goes into this patient.
There can be a risk of hepatotoxicity, but
What toxicity is that?
liver
Liver
might
toxicity. What is the dose that will produce liver toxicity?
that is around 10 times the dose, sir. So it will
What
be
will you do? What will
sir,
you, is there any method by which you can slow down the liver toxicity?
uh, we can do plasma pheresis, sir.
Before that,
Um,
any drugs?
N style cysteine can be given, sir.
Okay, right, done. Any other thing you want to give? You are given fentanyl, you are given paracetamol, then
And rectal route of acetaminophen can also be.
why you are already given IV. There's no need for giving two.
Okay, sir.
Any other method by which you can give pain relief? Because
Uh,
it is doing both lip and palate.
uh, we can before starting also we can give a infraorbital nerve block, sir.
How do you give this intraorbital nerve block?
Infraorbital nerve block, we have to first the infraorbital nerve arises in the infraorbital foramen. That is, we have to place a finger in the inferior border of the orbit and 1 centimeter below that inferior border of the orbit. We have to insert a needle and we will get bony resistance, that is the maxilla, and minimally we have to retract, we have to get back, and we have to give injections, sir, of around 1 ml on each side. Um,
Okay,
and that
right. Okay, fine. So now they have done the surgeon completed the surgery.
yes,
Okay.
sir.
So what are all the precaution that you'll take before planning to extubate the patient?
Before planning to extubation, I will try to see whether the hemostasis has been achieved. There is no further bleeding in the palate, and the throat packs or all the gauzes have been entirely removed, and no blood clots is available or any secretions is available, sir.
Okay.
Um, and I'll also check if there is any tongue edema due to the mouth gag that has been applied, sir.
Okay.
And then I will start extubating, sir.
Yes, I'll start to plan your extubation.
Plan my extubation.
Suppose your patient is a syndromic child. Will you
Yes,
do
sir.
anything more than that? You can think of putting a nasopharyngeal airway
Nasopharyngeal airway. Yes, sir. Okay, sir.
when the patient is really deep. Don't try to put it after do the anastomosis, after do the suturing and all. If you
Yes, sir.
can, if you are worried, put it before or ask the surgeon to put it because they'll have a good vision so they can
Okay.
put nasopharyngeal airway so that after extubation it will be easy for us. Okay, done. So how are you going to extubate?
After adequate recovery of muscle power, I would like to extubate the patient in awake state.
No. Tell me what are all the things that you'll check before even thinking of giving neostigmine.
Yes, sir. I would make sure that the patient's muscle relaxation has completely weaned off. So I will confirm the spontaneous respiratory movements and adequate ventilated rest. And
Suppose you are in a center where they give you some more monitors.
if there is a neuromuscular monitoring, I will see the train of 4 ratio and I will see whether it is more than 0.9 and then I will
No, for giving neostigmine, you want 0.9. You are not yet given
0.7.
your reversal, doctor.
Yes, 0.7.
9 or 7 or 6. These you have to be really sure, doctor. Even if you are not using it, these things.
0.7.
Okay. Any other answer from my audience? 0.8. 0.9 for giving reversal, for giving neostigmine.
After
Okay, just go on reference.
Okay.
Right. So you are given reversal. What reversal you want to give?
I'd like to give a mixture of neostigmine 50 microgram per kg and injection glycopyrrolate 10 microgram per kg, sir.
Okay. Then how you are going to extubate?
After adequate suctioning and I will place the patient in the lateral position and once the patient is completely awake, moving all the 4 limbs, respiration is regular, then I'll extubate the patient in the awake state, sir.
Okay. So what are the post-op complications you expect? Immediate post you expect in this patient? Post-extubation.
Post extubation, there can be increased due to increased airway edema. There can be a sudden airway obstruction due to either bronchospasm or laryngospasm, sir. Um, uh, um, there can be bleeding. So I will make sure I tie the patient's restrain the elbow or tie mittens to the hand so that the baby does.
No. Those things are not done now, doctor. You
Okay,
will
sir.
give a fairly good pain relief.
Okay,
You
sir.
allow the patient to cry. Okay. So
Yes, sir.
common post-op obstructions to the airway that you will see after extubation
Okay, sir.
of a Palate patient.
Yes, sir.
So these are the common causes. The
Okay, sir.
a wide palate, wide cleft in the palate.
Yes,
So
sir.
going inside the palate into the nasopharynx. Now
Okay,
the
sir.
surgeon has closed the palate. So this has produced a critical reduction in the size of the oral cavity. So the baby is not used to that particular size.
Yes,
So
sir.
there will be some kind of a difficulty in breathing for some time till the baby settles down. But until that time, you may have to take care of the baby either by nasopharyngeal airway or sometimes previously we used to take what is called as tongue stitch. That can be okay.
Okay.
Second important cause will be your sedation and
Yes.
all the drugs. So you'll have to take care. So most important thing they miss is one is cotton balls.
Yes, sir.
They usually pack the raw area. That small pack sometimes gets dislodged and they may become a foreign body. So you'll have to keep watching the sound and watching desaturation and watch the scribe. And the other two important or other three important post-op airway problems in a palate are laryngeal edema, swelling of the tongue, and laryngospasm. Swelling of the tongue, you can't do anything other than giving some steroids and wait for the swelling to settle. How will you manage laryngeal edema and how will you manage laryngospasm?
Laryngeal edema, we have to manage with giving a continuous amount positive airway pressure.
Laryngeal
And,
edema. You are talking about laryngeal edema?
if it is acute and causing obstruction striders. And
Laryngeal edema is different from laryngospasm.
okay.
Edema is collection of fluid in the mucosa that can extend up to trachea also.
Yes, sir.
Affected by what?
We can give a nebulization,
No,
sir,
that was created by what? That edema was created by?
due to the pressure and
So,
stagnation of
not
mucous.
pressure stagnation because of introducing a bigger size endotracheal tube
Yes,
or
sir.
unnecessarily moving the patient after endotracheal intubation.
Okay.
So, they is to increase the permeability of the cells and vasodilatation
Yes, sir.
to treat that laryngeal edema.
Yes, sir.
How do you treat laryngeal edema?
Laryngeal edema, we can give corticosteroids, sir.
Corticosteroid, how does it act?
Corticosteroid reduce the inflammation, sir. And
What dose? What corticosteroids? Which route?
I'd like to give injection hydrocortisone, 2 mg per kg for the patient, sir, around 20 mg, sir, intravenously.
Can't you
Start dose.
get dexamethasone?
Yes, sir. Dexamethasone can also be used, sir.
Which one is better, hydrocortisone or dexamethasone?
Hydrocortisone has an immediate onset of action, sir.
No, there are a few properties in hydrocortisone. One is a glucocorticoid activity,
And also mineralocorticoid activity.
so which one is required for this
For
anti?
us, we need mainly the glucocorticoid activity.
So which drug is better?
Dexamethasone has purely glucocorticoid activity.
Then which one would you prefer?
Dexamethasone.
How much is the dose?
Dexamethasone dose is 0.15 mg per kg, sir.
When will you give?
I'll give it half an hour prior to extubation, sir.
No, immediately after intubation you'll have to give.
Okay, sir.
Okay, right. And the next important problem is laryngospasm. How do you
Yes, sir.
diagnose laryngospasm?
Laryngospasm can be diagnosed with signs such as increased work of breathing and stridor, or if it is complete laryngospasm, there can be a silent chest without any movements, associated with the rapid desaturation of the patient.
Hmm. How do you diagnose means you do some maneuver that will tell you your patient has got laryngospasm.
I'll auscultate over the chest and also over the
If you keep auscultating, patient will go for bradycardia. What do you do when you suspect laryngospasm? What do you do after
jaw thrust, sir, and
no. What do you do immediately after extubating a baby?
position the baby in a semilateral position.
Then
And
you will hold a mask.
yes, sir.
You will keep whatever circuit you want. Would you like to
Yes.
keep the valve open or closed?
Valve closed, sir, for some
Valve closed. So you would like to give some kind of a CPAP.
positive pressure. Yes, sir.
Then you have a bag on your hand. Patient
Yes,
is
sir.
breathing. So
Yes, sir.
it's the one sign that tells you this patient is going in for laryngospasm.
Increase in the pressure of the bag, sir. Tight bag.
No, when there's laryngospasm, nothing will move.
Yes, sir. No bag movements.
You
Yes,
can see the chest wall movement, but there will not be any bag movement
bag movement.
associated with desaturation. If left untreated, go for a bradycardia and cardiac.
Bradycardia and cardiac arrest.
So this is the absolute emergency in any pediatric patient. Most patient with cleft palate operated. So
Yes,
how
sir.
do you manage this situation?
I'll immediately call for help and I'll apply jaw thrust and I'll give administer 100% oxygen with a continuous positive airway pressure, sir.
Still the patient goes in for desaturation bradycardia.
I would like to deepen the plane of anesthesia by using intravenous propofol, sir.
But you have sevoflurane with you, and you all
Um,
tight bag. I mean, a bag fully connected to the patient.
Inhalation agents won't be delivered to the alveoli due to the laryngospasm, sir.
Excellent. So never try to induce with the inhalation agent because the larynx is already in spasm. So only method allowed is propofol. What is it?
Dose of the propofol can be 0.3 to 0.5 microgram per
Why
mg per
not
kg.
give the regular propofol dose of 2 milligram per kg?
There can be associated hemodynamic disturbances, sir.
Patient is already hypoxic, hypercarbic.
Hypo-
You want to give a higher dose of propofol.
higher dose.
Okay, with propofol, it is not getting relief.
Then I would like to give a muscle relaxant, sir, and depolarizing muscle relaxant with a rapid onset succinyl sir.
Mhm.
1 to 2 mg per kg dose I
1
give.
to 2 mg per kg. Yeah?
Dose can be from even minimal dose also has been proven to break the spasm.
There is one point missing here. I'm very sorry. It is 0.1 to 0.3 milligram. It is not 3 milligram.
Okay.
A very low dose of succinylcholine. The whole idea is just to break the
Break
spasm.
the spasm.
Okay.
Okay.
All right. Any other maneuver can you do before all these things?
Yes, sir. Larson's maneuver can be done
What
by
is
giving
last
a
maneuver?
strong pressure over the styloid process between the mastoid and the angle of mandible. Give a pressure, sir, that can break the spasm in some patients, sir.
What is one of the commonest theories they say by which this breaks the spasm?
It will give a very high intense painful stimulus that will cause a reflex uh, uh, opening of the laryngeal inlet, so that is a glottic relaxation.
Any other reason? What is the nerve that is near the styloid process?
Facial
Facial nerve. It's glossopharyngeal nerve.
okay, sir.
Not been proved, but they say there could be one of the reasons for relieving the laryngospasm.
Okay.
Okay? Now we are in this state where you want to give succinylcholine. Due to back, the patient moved and the IV cannula got disconnected. The baby is now without any IV line. How will
Yes.
you manage?
I will immediately try to give intramuscular route of succinylcholine, sir.
How will you give?
5 mg per kg in the deltoid or the anterolateral thigh, sir.
When will the drug that you are giving the anterolateral thigh will reach the larynx?
Better to give in the deltoid region, sir.
It will not work because the patient already has gone for bradycardia tension.
Then I'll try to give in sublingual.
Only method is to give sublingual. How do you give sublingual? Ask the patient mouth.
No, sir. We have to immediately remove the mask and give sublingual.
No, you will have to go via the submental space.
Submental approach. Okay, sir.
First, enter into the tongue and give the 3 milligram per kg of succinylcholine with atropine.
Yes.
Right. Okay, you have done an excellent job. Now the final thing is the patient is going to be sent to the. So what are going to be your post-operative pain relief for this patient?
I will give a infraorbital nerve blocks, sir.
That you are given in the
Preoperative.
period. Intraoperative you are given.
Okay, sir. Then I will give a rectal administration of acetaminophen, sir.
Just
20 to 40 mg.
you are given only IV paracetamol maybe 1 hour back.
Okay, sir. And I'd like to repeat it after hours, sir. And
After 1 hour.
the duration is around 4 to 6 hours, sir. So
Okay. Based on the duration, would you like to give? If you got severe pain, would you like to give any narcotics here?
yes, sir. Morphine can be given in a very low doses, around 0.05 to 0.1 mg per kg, sir.
Which route?
And intravenously as a start dose, and we have to ensure that we have adequate monitoring trained personnel to observe for any apnea and respiratory depression.
Okay. You can give it as an infusion, either morphine or fentanyl as an infusion. You can, provided the baby is observed properly and everything is ready for reintubation or management. Okay, Dr. Gokul, thank you very much. It was a very nice presentation. Now to Dr. Amachi.
Thank you, sir. Thank you, Dr. Gokul, and thank you, Professor Krishnan, sir. And it was an excellent presentation. Very good job done, Dr. Gokul Ram. And I thank all the participants also for their patience listening and keen attention given to the entire more than 3 hours program today. I thank Professor Nagasamy sir for an elaborate and excellent lecture on burns management. And I thank our Professor Dr. Krishnan for a detailed, in-depth analysis of a pediatric case, as well as particularly airway-related cleft palate, cleft lip case discussion with Dr. Gokul Ram. It was very enlightening for our postgraduate sir, and we have recorded the entire session and we'll upload it to the YouTube tonight itself, sir. Thank you so much, sir.
Thank you so much.
Thank you, sir.